Yeah, I think that's the easy. Yeah, I know. And the panelists, are they not supposed to sit here already? Yeah, yeah, yeah. Or I can let them sit down as I can. Yeah, let's do it like this. One second.
Ouais, il est un peu stressé. Quand il dirait, je crois qu'il est proche genre de Stanford ou un truc comme ça. Ah ouais, ouais, tu peux être stressé quand même. J'annonce constamment d'être ici. Ouais. Connaissance.
Please.
I think
No?
it's best because there's first a video. So
Ah,
we'll have
okay.
a video,
Okay.
then I will introduce
Okay.
you, and then you.
Okay. Good. Good. Okay. Good to know. Good.
Maybe in the first, there on the scene or on the first row, as you wish.
I don't know. Let's just get started.
Well, that's how we're going to do the
Yeah.
video. Then I will
Yeah.
introduce you,
Fine.
and
Fine.
then say.
Oh, good.
Good afternoon, everyone. Welcome back. I hope you enjoyed your lunch. Yes. Now we'll continue this afternoon with three different panels. The first panel this afternoon is, I apologize, AI and data in social security, with the moderator here next to me, Professor Dr. Timo Minsen. Timo Minsen is Professor of Law at the University of Copenhagen. He is the founding director of the University Center for Advanced Studies in Biomedical Innovation Law, grant holder and PI of the InterCIBEL program, and and LML research affiliate at the University of Cambridge, welcome to the moderator as well as the panel members.
Thank you very much, and please, thank you. Your panel members, please sit down, yeah. Yes, welcome, ladies and gentlemen. We all have heard the phrase, the new drug is the data, or data is the new oil, as it was featured in The Economist. It is the new oil of the new digital and AI-driven economy, it was said. But as a matter of fact, I would like to challenge that notion. Data is better and more versatile than oil. One of the biggest advantages AI and big data hold over oil is their ability to continue existing at all times. Simply put, one day, all the oil reserves in the world will run out. Data, and by extension AI, on the other hand, can continue to evolve, unless you delete everything, obviously. And against this background, I'm very happy to share this first panel, which aims to address the inseparable bond between progress in the field of AI and fair access of data of high quality. As we all know, the quality of AI is based on the quality of data that is used for algorithmic training, testing, and validation. It is indeed garbage in, garbage out, as we have heard before. We have touched upon this before. The accuracy and ethical fairness and of non-discriminatory algorithmic decision-making also highly relies on the representativity of the population sampled in different data sets, as well as on the completeness, uniqueness, accuracy, validity, timeliness, and consistency of the data. This indicates already how important access to data will be, and recent EU initiatives and new regulations put much emphasis on this notion. One important aspect of this is the FAIR principle. FAIR stands for the concept that data should be findable, accessible, interoperable, and reusable. And with regard to the interoperability prong and the issues here, we need to distinguish between different forms of interoperability, such as semantical, technical, and legal interoperability. Moreover, legal interoperability is important for access, and in that regard, the as open as possible and as closed as necessary slogan is utterly important. Some actors, however, for example, actors in highly competitive industries or state security stakeholders, well, think about quantum technology, for example, and these kind of things, they will sometimes, for good reasons, want to keep as much control as possible on what data to share, with whom to share it, when to share it, for what reasons, and so on. They might prefer an as closed as possible and as open as necessary version of the slogan. This shows already how legal areas such as competition law, intellectual property rights, trade secrets, and privacy rights under the GDPR play a very important role within this area, and in particular with regard to access to data and interoperability. And not only trade secrets, by the way, also state secrets will become important. But we should not only think about hinders, concerns, and barriers, it is also crucial to focus on solutions for both utilitarian and ethical reasons, actually. And this is why I'm so happy that we could gather a great group of panelists today, all sitting here next to me. And so let me introduce the panelists. So I start with one of the organizers here, Anastasia Kiseleva, who is a researcher in law, health and technologies. She works on different topics, including AI in healthcare, the European health data space, AI-based medical devices, genetic testing, and editing with AI. So very happy to have you here with us, and looking forward to what you have to say. Then we have next to her Tuksche Schmidt, and please excuse me if I don't pronounce your name Tuksche correctly. Tuksche Schmidt is a researcher at Maastricht University, where she pursues her PhD as an external candidate within the research line Value-Based Healthcare. So, and your PhD topic is the governance of health data for integrated care with a focus on the primary and secondary use of electronic health records data. So that's, of course, a very important topic, and happy to have you in the panel, which has a lot of relevance for the issue we will discuss today. Then, next to Tuksche is Mikhail Czerniawski. Again, sorry if I pronounce your name not correctly. Yeah. He's a lawyer, a practitioner, very important, working for the Committee on Civil Liberties, Justice and Home Affairs of the European Parliament. And you specialize in data protection, information security, and transparency. So, thank you very much for joining our panel. And next to Mikhail, we have Margareta Acreditu. Correctly pronounced? Oh, sort of. Thank you. She is a legal officer at the European Data Protection Board, which she joined in May 2023. And again, of course, this is great to have you here because privacy and data protection and the real understanding of the GDPR is, of course, very important in this area as well. So let's now discuss the importance of data quality and accessibility for making AI-powered progress in social security and welfare possible, the relevant issues and the potential solutions. Specifically, we would like to discuss what is particularly pertinent for work capacity assessment in this regard, and I expect our discussions to also encompass the challenges and potential solutions and in ensuring data integrity and relevance. So the main aim of this panel is to clarify the challenge of data access in applying AI for work capacity assessment, inform on how the European health data space may aid in solving it, and how to make it in a way that respects the fundamental rights of individuals and other relevant challenges. So let's start now with the challenges, which is one of our subtopics here. Access to data as a facilitator for the development and implementation of AI in social security and work capacity assessment. So the challenge now, let's talk about the point that to ensure the high quality of AI outcomes, access to large volumes of data of high quality is crucial. So Tuksche, could you maybe describe this challenge more generally and also more specifically in the social security context?
Sure. Thank you, Timo, and good afternoon, everyone. It's a pleasure to be here. Hope you enjoyed lunch as well. And indeed, when we talk about AI, it is inevitable that we talk about good quality of data. And especially, it is a very huge responsibility for the social insurance physicians when they assess the work capacity of one claimant or a patient. Especially in the past, this focused on the rather classical medical examination of the patient. And more, what we see with the demographic changes and the complexity of the diseases, we need to see that patient or the claimant in a more holistic way, which requires even more data about that person. And again, in the past, maybe this was rather restricted to the causes of the disease and to what extent this person is still capable of working. But even more so, we focus in the past years on the second part, meaning the remaining capability of that person for the reintegration of that person into the workforce. So it is not only about the past, it is not only about the medical disability of this patient, but also using the capacity of this patient for future reintegration of that claimant into the workforce. And for that, we need medical data of this patient, but even more data that goes beyond the personal medical data of that claimant. So when we talk about medical data of the patient, inevitably what we need to think about is the electronic health records, and I think that we will touch on this issue in the framework of EHDS, the primary use of data. But even more importantly, what the physicians will need to assess is data going beyond medical data. And there I think, especially when it comes to predictive measures, AI can be a huge help. And this is a topic that I think we should embrace. So as we talked also in the morning, it is not to fear, but it is to understand, so how AI works, but also to capitalize on the positive aspects of AI. And when it comes to the data quality, I would say two things. So regarding the disease and the patient's rehabilitation needs, what we need to look at is high-quality medical data, that's for sure, but also the second aspect, breaking the silos between the data silos, so to say. It is not only the hospitals, or it's not only the medical records of one patient, but also looking at the different insurances. And in the morning, I was really amazed to hear that it is not only 27 member states, but 3,500 institutions that deal with social data. So do we want this? Do we want this transparency, that the claimant is completely transparent, regardless of where he or she lives? Do we want this predictability when it comes to the assessment of work capacity of that patient? I think these are the questions that we need to deal with. But one thing is for sure, we need to have high quality of data in order to make good use of AI.
Thank you, Tuksha. You talked about breaking the silos. I'm normally always very careful with talking about breaking the silos, because in the areas where I work, sometimes you rather would like to have some channels between the silos, connections, where you have a little bit of control still. And that brings me to a potential reaction of our privacy expert, Margareta, who might have some things to say about that as well. You indicated before you might have a reaction on
Okay, thank you. First of all, to say thank you for the invitation to be here today and participate in such an interesting panel. I'm here representing the European Data Protection Board, and as you can imagine, I will mainly focus on data protection and address some of the concerns that they already raised in one of the opinions issued on the European Health Data Space proposal. But indeed, I would like to make a comment on the quality of the data, because I think we'll have also the opportunity to discuss a bit more on the European Health Data Space proposal. But one of the main concerns, as expressed also by EDPB and EDPS, is about wellness apps and the fact that the data covered via these apps should not be subject to the scope of the proposal, because, and I think there are different questions on reliability of this data and data quality. And maybe I can address this a bit more in detail during my intervention, but indeed I think that this is an important issue on ensuring quality on the data that we have in order to have representative health data sets.
Thank you, Margareta. Very important comments. And we talked yesterday during the dinner, and I said, we lawyers, we sometimes feel when we act when we interact on this high-level AI parties, we feel like party poopers sometimes, right? And then I always say, we just want to make sure that you don't wake up in the next morning with a too bad headache. And that included both IP experts, but also privacy experts, right? So that is why it's so nice sometimes to talk about as lawyers to be finding solutions, to be a facilitator, because we should not only talk about barriers again, we should also think about solutions. And this brings me here to the next intervention here. So the European Health Data Space will, of course, provide the rules and infrastructure for accessing electronic health data to train and validate AI in the health sector. So Mikal, as the contributor to the EHDS proposal, could you give us some insights and perhaps also potential solutions, perhaps briefly describing how the primary and secondary uses of health data can help in accessing and use of data progress in medical research and science?
Thank you, Timo. Good afternoon to everyone. I can just complement the introduction, but that I'm a lawyer, a patient, and someone whose work capacity is being from time to time assessed. So I also, and working the field of privacy, I also know how important is trust. I think many of the people that are in the room are doctors, and they know how valuable is relationship between the doctor and the patient. So basically, when we go to the doctor, we reveal very sensitive information about ourselves. We tell them things that even sometimes our family members are not aware of. And then we are now reaching the stage where all this information should be put in the electronic system that will be cross-border one, and that could be available. The data from the system could be available to anyone with the proper access. That's why we need to build a proper infrastructure. That's why we need to put in place safeguards, and that's why we need to develop a system to which patients have a trust. This is the only way to achieve a good quality of data, because the patients will reveal the data, the patients will agree to have their data in this big database, to have them placed in this big database only if they trust the system. And in Europe, we are extremely lucky because in all the member states we have universal healthcare, something we don't have in, for example, in the United States. You know, someone once told me that the US IT systems are for billing and not for healing patients. So we also want, you know, to heal, to develop new medicine, to make some research progress. But for this, we need accountability. So, as Timo mentioned, currently in the European Parliament we are discussing a legislative proposal, a directly applicable regulation called European Health Data Space, which basically will put together data from all the health data from all the member states, and will allow this data to be used for research purposes, to use also by AI. AI is just an algorithm. Without a good quality of data, it cannot, you know, create anything. It cannot reach any kind of conclusions, and that's why, you know, there is this strong push to make health data of Europeans, which are good quality data, available to everyone. Maybe I will just focus on one thing that the European Parliament is currently insisting on. In each member state, we should have a body called European Health Access Body. So a body that will be in charge and will have control over who has access to data, and will monitor whether this access is taking place in accordance with law, and with relevant safeguards, with relevant data protection safeguards, with relevant cybersecurity safeguards, and in line with the conditions foreseen in the law. And I would like to stress here that we really need to build a system that is accountable, because otherwise we will not only not achieve this trust, but we may also ruin the trust between a doctor and the patient. Because if I'm a patient and I learn tomorrow that my data are processed by someone in Malta without my knowledge, I will go to my GP, I will go to my doctor, and I will say, look, I gave you this data, and now they are somewhere there. So the first step is to have a proper infrastructure in place. Such infrastructure will, of course, require huge investments of funds. So this is a big question: who will finance it? Member states of European Union. And only when we have the proper mechanisms, the proper infrastructures, we can talk, you know, about uses and about how to benefit from this data.
Sure. Couldn't agree more, Mikael, but maybe let's also get a little bit into the dimension of social security in workplace assessment, work capacity assessment, sorry. Anastasia, I think you have some remarks on that dimension. So how does the European Health Data Space proposal cover use and reuse of electronic health data in the social security and work capacity assessment is one question we would need to ask. And the second question is, if the EHDS proposal allows the use of data for work capacity assessment, how would it affect the sector? And the third question is perhaps, how would it aid in unpacking the opportunities and leveraging the opportunities of developing and using AI for work capacity assessment?
Thank you, Timo. Hello, everyone. I'm really happy to be here. It's such a great event. I also should say that I do believe, I advocate for the EHDS, for the European Health Data Space, and I do believe that we can reach the goals of accountability and trust that are described by Michal. And as I do believe in this initiative, because it really helps to unpack the opportunities promised by data. And without data, there is no AI. Sorry to be trivial, but it's true. And so where does the social security and specifically work capacity assessment stand there? Is it the part of this great opportunity or not? And I have some good news. It is the part, at least from my analysis of law. There are two regimes of using data, primary use, My Health EU, this is what Michal described as interchange between EHR system across member states. And the definition of the primary use says that its use of data besides for the provision of healthcare services, but also for the relevant administrative, social and reimbursement services. So what does it practically mean? Well, essentially it means that any healthcare insurance advisor or general practitioner who assess work capacity would have a chance to get access to this data, if of course the law is adopted. And of course there are also differences how data is provided, because there are differences right now in different policies of work capacity. There might be direct access in some member states, there might be also access through the general practitioner. But it's important to be the part of this initiative because, as you can imagine, work capacity assessment, essential part of it is medical assessment. And of course, medical assessment is impossible without health data. And as we discussed, also collecting data requires a lot of administrative work. It includes not only health data from individual, from a patient and medical assessment, but also collecting data from different institutions of regional and federal level. So if this task or time spent on this task can be reduced, we should definitely use this opportunity. And the EHDS is actually one of them. And then besides also primary use, there is also secondary use of data, which is also the infrastructure among health data access bodies of data that is specifically used also for AI capacities. And again, also the purposes of secondary use specified in the EHDS proposal also specify the development and innovation activities in social security sector. And besides also the purposes, the scope of data mentioned that should be added also to the secondary use includes, besides health data, also data about professional status, educational status, data from interviews, which is also the part of work capacity assessment. And again, this is very important because that will also help to reduce the disbalance right now of accessing data, because it's now shared not really equally among companies. It's in the hands of big companies, for example, and also among sectors, because these big companies actually define where to invest data to train AI. And so if the EHDS also allows to reduce this disbalance, it's also important that the social security sector is there too, and it's great that the scope of data allows to do that because, because work capacity assessment indeed like includes not only health data, as Tukchi mentioned. I think this is my answer.
Thank you very much, Anastasia. So this is all very exciting and interesting. One issue which we inevitably will have to address is, of course, especially when we speak about the secondary use of health data, is, or two issues we will have to address, actually, not only one, is, of course, the impact this secondary use of health data has on IPRs, intellectual property rights, and trade secrets, right, which is a huge concern to big pharma, for example, and many innovators. We will not touch upon that too much today. We go to the other elephant in the room, and these are the privacy rights, right? And so, Margareta, could you elaborate a little bit on that, where you see issues, challenges, but also opportunities in this regard? Thank you.
Thank you. First of all, I hope that I don't look like an elephant.
No,
so I'm not taking it personally.
No, the topic does. Not you.
It did. I think we all know that GDPR, in theory, allows a sharing of secondary health data. There are a number of potential legal bases that can facilitate this. And the GDPR cannot be said to be hostile to research. And I think this is something we can all agree with. The problem is that the way the GDPR has been implemented so far, and on this, please don't quote EDBB, but it's Margareta speaking. Many people would argue that has not resulted in an optimal sharing of health data, including secondary health data. And I think this is one of the challenges that EHDS needs to address. And I mean, as I said before, there is an opinion provided by EDPS and EDBB on the European health data space and proposal, and I would like first to say that they both acknowledge that the secondary use of health data may generate considerable benefits for the public good, considering also the objectives of the proposal, which is enabling research, fostering innovation, and of course leading to better healthcare delivery. But there are still a number of concerns from a data protection perspective. And I think as a general remark, what we need to say is that the provisions of the HDS come to add an extra layer of complexity, if I can say this, to the already quite complicated collection of provisions, both at national but also at EU level, when it comes to health data and to the processing of health data. And just to give you an example, Article 9 of the GDPR, paragraph 4, actually gives power to member states to further specify conditions for the processing of biometric health and genetic data. And these conditions may differ between the member states. And I know it's not always the case where you can sit next to someone really participating in the trialogue. So this is why I really want to pass some messages with the hope that this can be heard while the negotiations are still ongoing. But I think what is really important for the proposal as it stands right now is to clarify the link between the conditions included now in the proposal with the different conditions in member states, but also to find a way to reconcile this divergence between the different member states on how to process health data. And moving now a bit to the topic of data subject rights, and I would like to bring to the discussion one of the concerns linked to transparency, which I think is a word we all heard during today's symposium. And I would like to mention the fact that at the initial proposal as provided by the Commission, there is an exception on health data access bodies that we heard before. Michael explained to us what their role will be. And there is actually an exception regarding the transparency obligations under GDPR. And based on the text as was initially proposed, the data health access bodies are not obliged to provide information to data subjects regarding the use of their data. There is only one general application on providing information on all data permits issued. And why I'm mentioning this? The reason is that while the objective of the proposal is actually to contribute to, so that the data subjects have power and control over their data, having actually this provision that does not allow data subject to know all about the processing of their data, does not really contribute to the objective of the EHDS. And maybe just to say also something linked to and more pertinent to the context of work capacity assessment, which is actually linked to the primary use of health data, is the fact that the concept of health professional encompasses a very great variety of different professions of distinct nature, with different roles in decision-making and different sort of involvement, including nurses, doctors, nutritionists, physicians, and these are just a few. So how we can make this, how is this actually pertinent for the work capacity assessment? Because by giving indiscriminate access to all the health professionals, to all these data, this clearly has an impact on data subject rights. So what we suggest is giving access to health professionals only to the data that they are relevant for the context they are working on. And this is just to ensure that both data subjects, but also health professional liability is correctly addressed, because in this way we are all in compliance with the necessity, proportionality principle, but most importantly with the data minimization principle as enshrined in the GDPR.
Thank you, Margarita. These are also extremely important considerations, and learned a lot also by listening to you. This is all very important. Thank you so much. I'm also thinking you talked about data subjects' rights, right? And as we know, for an efficient healthcare system, the relationship and the trust between patients and healthcare professionals is, of course, absolutely crucial and very important. Now that healthcare professionals might have access to this vast amount of data, how do you see the impact that this will have on the relationship between doctors, healthcare professionals, and patients? Do you see any risks, challenges, possibilities? Mikhail, you told me before that you had some concerns there.
That's correct. So during the coffee break, I had a very quick but very interesting chat with someone from Finland, where they already have a system like this. So they have an electronic health system for a whole country. And actually in Finland, the rate of you cannot withdraw from the system, but you can ask for the data to be hidden. But the percentage of patients that hide the data is relatively low. And as I understand, this is because of the fact that Finns in general trust the country, they trust the government, trust the state. And another reason might be a bit cultural. Also, the countries in the north are more transparent. They have, being Danish, you don't hide things from others. But this is not the case for all the countries in the European Union. There are countries like Germany with very strong data protection and privacy traditions. And this brings us to the real elephant in the room, so-called opt-in and opt-out systems. So opt-in meaning I need to conduct an affirmative action to be part of the system. Opt-out means that I'm automatically added to the system, but I can be excluded from from the system. And of course, less people participating in this health system means lower quality of data. And the discussions we currently have with the Belgian presidency, the heated discussions, one, I believe the opt-out and for secondary and opt-out for primary use are one of the, like, two of the biggest topics that are still being discussed, because we need to find a compromise how to give patients choice without affecting the quality of data. And we have different ideas currently on the table, for example, opt-out, but with certain exceptions and limitations. So a catalog of situations where you cannot, as a patient, opt out from the system. But this is a very sensitive issue, because if we mess things, if we do something wrong, the patients will be not willing to participate. The patients will be not willing to give their data. If we force them to do it and they don't trust the system, they will even may resign from healthcare. They may not go to the doctor, being afraid that their data will be shared with with someone they do not know. And at the very foundation of this situation is the something you mentioned, and I already mentioned it before, a patient-doctor relationships. So the human interface in the whole system is a doctor. Then we have AI, we have some infrastructures, we have electronic services, and we need this trust also for people to keep trusting doctors.
Yeah. Sure, and it's questionable if synthetic data can help us there. But yeah, the human in the loop is of course very important. There's also, it reminds me of a great paper by one of our core partners at CBIL, Professor Glenn Cohen from Harvard Law School, who wrote a paper on the duty to share health data, the ethical obligation to share health data. So this is, also regarding the AI topic, right? It's very important to talk about the risks of AI, but also the risks and the ethical implications of not using AI. Because oh, sorry. Okay, right. I'm not always used to that. Great, yeah. So I was just talking about this. Also important to think about the duty to share health data, and also the risks, the ethical risks and the ethical implications of not using AI in certain situations. For example, if AI makes cancer surgery much more precise than human surgery.
Just maybe to one thing. I understand, like Finland, I mentioned at the beginning, is an example of the success story. So where they did the thing right. So it's possible to do the thing right, to find a proper solution, but it's much more complex where we have 27 member states. Yeah.
Sure. And I know, Anastasia, you might also have some comments on this topic.
Yes, that's really one of the most important topics around the EHDS. And I think it's really important also to differentiate between the choice of individuals in primary use, which is the use of individual data, of personal data, and secondary use, which is the use in anonymized or pseudonymized format. Because the risks are really different, and I think we should differentiate the approaches also. For primary use, even though I'm really optimistic, but I also have some, I'm also reasonable, I do believe that in primary use, patients should have the choice. Here I should also agree and refer to the recent paper position of the Standing Committee of the European Doctors, who also suggest that patients should have the right to restrict and object data in primary use. Because indeed their trust, especially when they interact with healthcare professionals, with doctors, is essential, because we also receive data from them. That is necessary, again, later to save other patients. So here I should say that it's a good choice to have to give the choice to patients. For the secondary use, I advocate for more flexible approach, because indeed, as Timo also mentioned, sometimes non-using AI, which also means not having access to data to train AI, might also endanger the population, and we might just lose all the possibilities that AI promises to bring. And for that, of course, we need more data, and when, for example, everyone opts out, then we have less data of less quality. Also for the primary use, I also like to say that it's also important to, following up to Miha's comment, that the trust between healthcare professional and patient is important, and actually it's also a good source to raise awareness of benefits. As you just also described the positive use case of Finland, I think this was also mentioned in the opinion of the European Economic Social Committee on the EHDS as well, that actually physicians are the key figure to raise awareness and actually to motivate patients to trust the system, actually. So, yeah.
Thank you so much. Well, we could talk about this forever, and of course also the question of international data transfers and the Schrems 2 and possibly Schrems 3 developments. We could also talk about quantum de-encryption, which might mess up some of the encryption systems that we have right now, which is the future. But anyways, before we get to all this, I think I would like to talk about some remaining solutions and challenges for the professionals in work capacity assessment. So, Tukshe, where do you see the biggest challenge in the implementation, which is always a very important thing to consider, implementation of AI solutions that should support work capacity assessments?
Thank you. And I think I will also touch on the information gap, especially when it comes to electronic health records, because as we mentioned, if the health systems or the data processing systems are trained on a wrong basis, it is of course hard to trust on the AI solutions that are fundamentally based on these algorithms as well. Trust, I think it has different phases. So we mostly talk about trust of the patients to the governments or governmental institutions, to sickness funds, social insurance institutions, and so on and so forth. But the end user of the AI solutions, especially when it comes to workforce capacity assessment, it is not only the patient. So we do rely on the patient's data, that's for sure. So we need high quality data, ideally without any gaps. Also here again a bracket, it can be that we have an opt-out system, but what do we do with a bunch of electronic health records without the right data? So if it's also a question if the patient is allowed to delete this data, and me as a physician, let's say, I take a decision on that basis. And to make this situation even worse, the secondary use of data, so we accumulate all these electronic health records, and then we, let's say, extrapolate it, and all the decision or the guidelines, let's say, are based on some wrong information that we have from individual electronic health records, because so data was simply not there. This is especially important when it comes to some illnesses like mental health diseases or some more discrete diseases that patients do not want to share with their physicians. So here we need to have some caution. And indeed, on the first hand, we need the trust of the patient or the claimant, so between that person and the governmental institutions. But as mentioned earlier, so the end user of the AI solutions, it won't be only the patients, it will be also the physician. So what are the challenges of the physicians when it comes to this assessment? So the physicians should know that this AI solution is reliable. And for that, we need to have good quality of data, but also a safe space for the physician to work on this, let's say, algorithm or the developed AI solutions. So the regulatory agencies in member states, we have different regulatory agencies, so I use this term, but of course at the EU level we give guidance thanks to AI Act or EHDS. So if they are very harsh, as we heard in the morning, getting penalties, high penalties, people getting jailed. So if these are the consequences, then of course they are hesitant. So of course they will not trust completely. So when we talk about trust, I think we should unpack this term a bit and also make it a bit more operational. So when do I trust this AI solution? I trust this AI solution when I know to what extent, so I can rely on the information that I get from the solution, and to what extent I should complete the solution. And I think this will be always the case, so it won't be completely AI that will lead the work capacity assessment. But also, I am comfortable within this framework that is given to me by the regulatory agencies. So I think it is not one-way direction, so it takes kind of a team effort, a group effort, so from patients, from physicians, but also from regulatory agencies, that they create this safe space for people to test these solutions. Yeah.
Thank you very much. That's certainly also very true and very important. So to test the solutions, I think at some point people will demand to be, for example, treated by an AI. I think this will come this time, but of course it depends on the success of the system, right? The product adoption and the adoption of the technology depends very much on the success of the system. And what this means for insurances and so on is also another question, liability questions, but we can't tackle all of this. What I think is important also when it comes to anonymizing data, encrypting data, we have to be very careful that we follow up with the technological developments. I just mentioned the quantum de-encryption developments, which I think are a worry for the future. So it's important that the entire system is gearing up towards this and that we have, I think, strategies that have different layers for these new developments. But okay, Anastasia, how do you think that the European Health Data Space proposal and its implementation shall support or will support work capacity assessment?
Thank you. As you can guess from my approach, it will support. But I think the most important thing that the EHDS proposal does is the harmonization to the sector. And we need harmonization if we want the European Health Union, and we need harmonization if we want the EU to be social union. And similar to how also the EHDS brings closer different health policies, it might be also a good chance to do the same with work capacity assessment models. But when I say harmonization, I don't mean making it identical, because we still have to respect the competence of the member states to define their policies in health and also in social security. When I say harmonization, I mean making it more compatible and connected. And I think it's also important to support and facilitate this connectivity and compatibility during the implementation phase of the EHDS, because one thing is to adopt the law and another thing to make it in real life. And for that, also during the implementation, it's also super important to understand the differences in different models, because in work capacity, like in different states, the definitions are extremely different. For example, what is the long-term disability? It might be 1 month in one member state, 3 months in another member state, or when rehabilitation is considered to be successful, it might be after 1 day, or it might be after 6 months. And these types of differences don't really make it easy to make the social protection healthcare cross-border. And we need to have it because otherwise we cannot guarantee the same high level of protection and healthcare provision. I know that, for example, before the HDS, there was a lot, and it's still ongoing, a lot of research on differences between health policies. And I know, for example, that the research was also made by UMass on understanding like the differences in, for example, the role of insurance physician in work capacity assessment. It's done by Anna Devin and colleagues. And I think this type of research should be continued by the key stakeholders in the sector. So to understand first the differences, and I think the European organization in the sector has the great capacity to do that. To compare, and then based on that also to develop harmonizing policies. And of course I speak about data governance. I don't speak about all the things in the policies, but I think it's really important to facilitate this connectivity and compatibility in policies of different member states.
Thanks. Very important remarks as well. I have a look at the time. If we want to have some questions from the audience, I think we should continue. Sorry? It's 10 minutes left.
It's 10 for just the discussion, right?
Including questions from the audience, right? So, very quickly, from a very practical perspective, Tuksha, when physicians... Okay, I was just distracted by the time. Okay, all right. Okay, so I relax. It's cool. Okay, good. You know, I live in Sweden, work in Denmark, but I am German, so the time thing is always like, bring up my pulse. Sorry about that. So, okay, so I will cool down and ask Tuksha, where do you think, from a very practical perspective, what are the needs of physicians that are involved in work capacity assessment that want to use AI systems? So where do you need the...
So I think in the morning what I really liked was the example of self-driving cars. So we are, of course, not there yet. And also due to the high risk of using AI in work capacity assessment, there will be always some human oversight. So it will be a combination. But what physicians need is really, as highlighted, having this safe space and understanding, you know, when is the AI useful for my work? We need kind of a feedback loop. When the physician takes a decision, it's mostly the advice. When the physician gives the advice, was it useful? So I use, for instance, AI in my decision. Was it more beneficial? So was it more accurate? And when do I use AI? So is it like at the beginning? And then is it more like a chat with a nice colleague, with a knowledgeable, wise colleague? And so is it like back and forth? Or is it like, it depends also on the nature of the work. So if it is administrative work, it is maybe 80%, so done by the AI. And I do the quality check at the end. So this kind of, let's say, trial and error, and I know in public policy, the trial and error is not the best terminology, but it is really like giving them this kind of safe space so that you create this organic relationship, which is also leads to trust at the end.
Great. That's, of course, very important. And Mikhail, also to you the question. You already talked about the importance of the robustness of the design of the European health data space, right? And could we get back to that and think about these important issues such as that it's predictable, reliable, and trustworthy? What do you think? You mentioned some of that already, but what do you think are the main traits of this design?
I think, so there are two layers. Maybe in my first intervention, I focused more on infrastructure, but there are also some political choices to be made.
Yeah.
And one of the issues, for example, we are currently discussing is the topic of the data localization. So whether to store the data of European patients, shall we aim to impose obligation to have them stored in the European Union, or should we allow the storage from outside of the EU? And there are actually some polls already made which show that one of the biggest fears of the patients is that their data will be moved to another country, the health data. So basically, there are some fears that we need to addressed. But looking at the whole system from a holistic perspective, we'll have a doctor, or we'll have a hospital that will be a data holder. So that's where the data will be collected. Then for the secondary use, we have this health data access body that basically tells data holder to whom you can give the data, to whom you cannot. You mentioned, for example, intellectual property rights. This is something, at least in the Parliament version of the text, we want the HDAPs to assess the IP rights issue. So for example, HDAP should be able to prohibit access to data, or reject, like, the request based on the IP rights. And then we have data users, so those who will be using data. I'm talking now mainly about the secondary use. So this can be pharma companies, big tech, and this brings us to another issue, because unfortunately, many of those companies are non-EU companies, and what will be the supervision of them if for example the data are outside of the European Union? The Belgian, data protection authority or digital health authority, it will be much more difficult for such an authority to reach out, to a US company and check whether they are aligned, they are following the law. So there is like a number of questions about the structures, as I said, like very briefly, on both on the level like of law and infrastructure, but also there is a number of political choices to be made.
Certainly, and reciprocity, I think, should also play a role. And I just started to study, I haven't read it all through that, but there's a Biden order on the protection of US data, which is quite new. I'm sure that you, Margareta, will also probably have a look at this very carefully and compare that. Also with regard to cross-Atlantic data transfers. So from a GDPR perspective, do you think we're all geared up for these new developments? Is all fine with the law? Do we have enough flexibility in the law to react to this? Or what do you think, where do you think there are additional challenges that we didn't mention yet in the GDPR?
Indeed, actually, I would like to reply, or maybe provide some recommendations to what already mentioned by Michal, and just a comment on the recent also order. We were also quite surprised of seeing this term used by the US for countries of concern. So indeed, with a lot of interest, we will follow these updates from the other side of the Atlantic. I just want to touch a bit upon the fact that, as Michal mentioned, I heard two different public bodies, the Belgian Public Health Body and the Belgian Supervisory Authority, and this is something that I would like to stress, that with regarding the governance mechanism, I think it's really important for the co-legislators when designing these tasks when discussing these tasks of the new public bodies, to take into account the fact that there should not be an overlaps with the supervision authorities, the data protection authorities, that they already exist, monitoring the application enforcement of the GDPR. And then I would also like to make a comment on another another quite heated topic currently discussed. The fact that due to the large quantity of the data and also like the sensitive nature of the data, but the need for an effective supervision, I think it's crucial for the co-legislators to include a provision requiring the storing of this data within the European economic area without, of course, prejudice to transfers of this data in full compliance with the GDPR. And another comment on the infrastructure. I think what is important is to make it clear that we are talking not about the creation of a central EU health database, because as we all can imagine, this would be super attractive for hackers and potential to cybersecurity threats. The idea is that the infrastructure will facilitate the exchange of this health data from decentralized database. And in my last 40 seconds, just a comment on the need to secure to ensure like secure processing environments which need to comply with very high standards of security and privacy, and to clarify that no personal data should be downloaded from such environments. We do need to keep up to date with the latest trends in encryption, as you mentioned, and to make it clear that when we are talking about secondary use of data, this should be anonymized data, or worst case scenario, pseudonymized data that should not lead to the re-identification of the data subject.
Yeah, there's a saying in criminal networks, you know, store first, decrypt later. And that is quite scary when you think about what's going on in quantum computing and quantum decryption, but also encrypting. So we have to be very careful and aware of that. So I would like to thank the panel for this amazing discussion. Thank you so much. And I also, now that we have like 28, 29, okay, now it's going up. Okay, we're over time, it's red. Oh my goodness, yeah, I'm just like, so yeah. So do we still have time for questions from the audience? Yeah, so okay, so thank you very much. And I would like to open the floor for audience questions. Thank you. Now it's white again. Oh yeah, so 10 minutes for audience questions. Yeah, please. Yeah, please, over there, yeah.
Okay, thank you. Thank you for this panel. I have a question for Michael. I was quite surprised because, Michael, you said that, well, the negotiation around EHDS, it would go in, we would go for an opt-out for secondary use and an opt-in for primary use. Did I understand? Well, is it correct that I understood that?
It's partially correct. Okay. I said that this will be the topic, these are the topics that are the most controversial and that still are being discussed, yeah.
So I have a second question then, because I would be afraid, well, opt-in, of course, we will have, as you said, we will have less data from the opt-in from primary use. And I was seeing that the secondary use was coming after the primary use, meaning that the data collection, it will be during the primary use moment by the physician, and from there will be data that will be used on the secondary use. But if there is not many data because it's an opt-in in primary use, wouldn't it be a problem for the opt-out and for the secondary use thereafter?
So, can I just immediately? I didn't want to jump in during the discussion. I think Tunja mentioned it during her interventions. Opt-out, opt-in are basically buzzwords, you know, very general concepts, and then the devil is always in the details. So opt-in can be interpreted that you don't have the data at we discuss very many different options. One option is that you have the data recorded in the electronic system, but only by the data holder, and then they are not made available to other data holders. So for example, I go to my general practitioner, my GP has my health data, but she or he does not share it further. There is another idea of restricting access to certain kind of data. So for example, the examples we discussed, the data about abortion, for a very simple reason. In some member states, abortion is legal. In some other countries, is illegal. So if I'm Polish, if I go to Poland where the access to abortion is very much restricted, and then my GP in Poland can see, like I couldn't, but let's see, someone goes to Poland and undergone abortion, this may cause some troubles. The other example is some, treatment, mental treatment, that you should be able in certain situation to not agree to have this kind of data shared with anyone else. The most radical version of the opt-in, which we also discussed, was that you don't have your data at all put into the electronic health records, so that all the data stay in analog or are not put in any kind of the system, even of the in the system run by a data holder. So there are really different versions. These are buzzwords, opt-in, opt-out are buzzwords, and it's all about specific choices and
Right.
nuances.
Great. You can see how much expertise we have here. So if you ask questions, you can
Happy to
expect
discuss
elaborated
it.
answers on many levels. So very good. Thank you so much. And please, when you ask questions, basically also very quickly say who you are and where you're coming from. That's always very interesting. So Professor Stephen Gilbert, you have another question.
Professor Stephen Gilbert, Technische University Dresden. I have a question which is relating to the previous point, but very specifically looking at wellness data, wearables data, sensors and apps. My question is how many years, if we're not very careful, to guard meaningful consent of users to how data from their wearables and wellness apps goes into their electronic health record? How many years will it take before a tipping point where something that Mikhail hinted at, people actually stop sharing data? Will we not get a differentiation in the system where the rich and intelligent don't record their data, or record it by Apple, who've recognized this phenomenon and will not share further, and the poor, the less intelligent and the less protected, will share data, which will almost always be their detriment when it comes to insurance and to social security situation?
Very good question, which I also have heard before in many contexts. So any comments from our panel about this? That the privacy is for the rich, basically. There's a risk for that.
Indeed, I don't think I have an answer to how long it will take, but I fully agree that this data generated by wellness app and digital applications should not be subject to the secondary use for different reasons, mostly related to reliability and data quality, because these applications generate enormous amount of data. They monitor almost like our daily lives, every step of our life, and it is quite easy to lead to assumptions that are not always accurate, but also inferences such as even based on profiling conclude on religious orientation and other sensitive data. So if in the end these data are in the scope of the EHDS, I think it's really important to ensure that for this we are not so flexible, but we have clear consent of the data subject as provided in GDPR, and the data after the data subject is informed and can actually decide whether he or she wants this data to be part of the electronic health record system and thus subject to secondary use. And we also need strong mechanism to ensure that this choice is respected.
certainly much more to be said in this area also with regard to data colonization and these kind of notions. I cannot agree more with what you say, Margarita. So any further questions, remarks? I'm sure we have more over there. Yes, thank you.
Yes, good afternoon, everyone. Dan Ayels from VOCA, Chambers of Commerce. Thank you for the interesting discussion. You touched with the previous questions upon opt-in, opt-out, and the correct information of people donating their data, giving their data, or making it available for primary use and secondary use. The concerns are always about security, about consent. Are we informing patients enough about the potential benefits of sharing the data? Meaning they could get better treatment, more precise treatment when they're sharing their data. Are we taking this up in the discussions within the EU Parliament?
Yeah, please, Mikael.
I think this one is for me. Yes, we discussed the whole topic of information obligation in general, because there were, for example, voices that the information should be provided online, while many patients are elderly people, and I don't have like a specific answer to your question, but definitely informing also about benefits will be a challenge, because I cannot imagine that information on the wall in a hospital will be sufficient. I don't think if we give a leaflet to a patient, they will read it carefully. But I fully agree that the patients should be aware that consenting, in case we have, for example, opt-in for the use of the data for secondary purpose, has some specific, has some benefits for society, for example, for a society as a whole.
Thank you, Mikael. I also think that incentivation is extremely important, not only for patients, but also actually companies, so that you also have a system for that. Yes. There's one more question. We have 11 seconds left. So last questions. 10, 8, 7.
Thank you. Yes, a bit in reaction to Professor Gilbert's comments. We hear a lot about how trust in the Scandinavian nations is higher. Should not the approach be to improve the trust where it is not as high, rather than fearing this? And linked to that question, I'm quite optimistic about the EHDS, but one of my biggest fears is that the health data access bodies are being asked to do an impossible job. Do you have any short comment on this?
We need 2 hours more now, because hospitals are underfinanced. So that's a very huge discussion we are having as well. Who should bear the burden of all these obligations and duties? We cannot, ask general practitioners of hospitals to verify, for example, intellectual property rights. We cannot impose on them duties related to verification of data permits and this kind of thing. So health data access bodies are basically the only entities that can do that. But the costs, of course, will be high. And in many member states, healthcare is already now underfinanced. We cannot impose this kind of obligations on hospitals. And
yeah. Thank you very much. Please give a hand to the panel, and thank you.
Thank you very much for this panel. I also would like to thank the moderator for this insightful yet entertaining panel. Thank you very much, Professor Dr. Timo Minsen. Now we'll continue with our next panel. You've already met her as a speaker, but she's also the moderator for this next debate, this next panel. We'll continue. Yes, you have to keep sharp. So she's Anastasia Kiseleva. We just mentioned her as one of the organizers here today, but she's also a researcher in law, health and technologies. She works on different topics, including AI and healthcare, the European Health Data Space, AI-based medical devices, genetic testing, and editing with AI. Her papers were top listed by publishing journals and cited by the European Parliament and the European Commission. Anastasia acts as an external AI policy expert at HUMAS, and that's why she's here with us today to share her expertise, but also to moderate this next panel addressing challenges of implementing AI in social security and work capacity assessment. Please give them a hand for this next panel.
Hello, everyone. Just give me a second. I just need to change because I was just here like 1 second before, and I also would like to greet our panelists. I just need my bag. I think it's it's not here. It's okay, no worries. I'll be back to the stage. No, I just need my notes, sorry. Sorry. I memorized everything, but I just need my... Yes. But there is also yellow... it's here, okay, thanks. Okay, I'm safe, sorry. Thank you very much for waiting. I'm sorry for that. It's my great honor, and you can also recognize my face. I've been here before. But it's my great honor, and I also will stand for that, to welcome you to the second panel. If you didn't have enough challenges, we have some more for you. But it's not because we love challenges, it's because we like solving them. And I'd like also first to welcome our speakers. Mr. Pedro Facon. I will introduce everyone later. I just would like to give the chance to take a seat. Hello, Mr. Facon. Sorry. Yes, sorry. Then I'd like to invite Professor Paul Quinn. And the next one is Professor Stephen Gilbert. Please take a seat. And you can also welcome our panelists, but also a bit later. And the last but not least is Mr. Jordan Maris. So I'll take this seat because I feel a bit more connected also to the speakers. Before we start, I'd like also, I'll take also the switch. Before we start, I'd like to thank all the HUMAS participants who participated in the survey. It actually helped a lot to shape the scope of this panel and also to help to discover a lot of issues and opportunities. We are going also to use some quotes also from the survey, so don't be surprised if you see a quote. And of course it's anonymous, but if you want to say, hey, that's me who said that, you can also say that during the Q&A session, or just blink or raise your hand or do whatever you want. And the first quote, I think it's really nice to emphasize the scope of this panel. Someone from Belgium said that it's important to welcome AI with an open mind, but to remain critical about how and under what circumstances to deploy it in social security. And indeed, AI applications in work capacity assessment are really demand that are really expected and really welcomed by the humans community. And when expectations and hopes are so high, it's crucial to make it right since the very beginning. The earlier we identify and fully understand the challenges, the better chances that we successfully address them in due time. And this is the scope of our panel. We are going to discuss 3 critical issues: safety and quality, bias and discrimination, and lack of transparency, and of course the solutions to address them. And now it's my great honor to properly introduce you our panelists. First, I'd like to introduce you Mr. Pedro Facon. He's the Deputy General Administrator of the National Institute of Health and Disability Insurance in Belgium. Mr. Facon stands as a key figure in the landscape of public health in Belgium. He has a multifaceted background from academia to high-stakes crisis management. And he is recognized by the public as a Corona Commissioner because he was leading the response to the coronavirus crisis in Belgium as a government commissioner. Please welcome Mr. Facon. Then we have Professor Paul Quinn. He is the founder and director of the Health and Aging Law Lab and professor at Law Science Technology and Society Research Group at Vrije Universiteit Brussels. Professor Paul Quinn is involved in many research activities that are shaped around health, law, and technologies, including privacy, data protection, discrimination, and stigmatization. Health and Aging Law Lab, under the lead of Professor Paul Quinn, participates in several Horizon 2022 projects, also solving issues on aging and health. And enjoys also interdisciplinary collaboration also with healthcare professionals, scientists, and so on. Professor Stephen Gilbert is the professor in medical device regulatory science. He works, now I need my notes, and I will change also back to the screen so that you can see better the speakers. Professor Stephen Gilbert works as a professor of medical device regulatory science at the Else Kröner-Frenius Center for Digital Health, Technische Universität Dresden, where he teaches and conducts research on regulatory science. He worked in senior medtech and digital health role in industry for 5 years, and then he returned back to academia in 2022. His research goal is to advance the regulatory science of software and artificial intelligence as medical device. And finally, I'd like to introduce you Mr. Jordan Marius. He's a digital policy expert and senior policy advisor to the member of the European Parliament, Karen Melchior. Mr. Marius was involved in the negotiations around the AI Act, and specifically he focused on transparency and explainability obligations. He also worked on other digital policy files such as Data Act, Data Services Act, Digital Identity Act, Product and AI Liability Directive. Thank you very much, and please again welcome our panelists. So now, without any more suspense, the first issue that we are going to discuss is the safety and quality of AI applications. And this issue is crucial and very much dependent on the key stakeholders because their acceptance actually defines the success of the technology. And this acceptance also relies on how trustworthy and reliable the technology is. Pedro, I would like to ask you, as you represent one of the key stakeholders, to share your opinion on the importance of safety and quality control of applications, and how do you think they should be verified, and what kind of elements should be also controlled?
Thank you.
Thank you, and congratulations with the conference that is being organized. And maybe start with the beginning. It's very good that we have a debate on safety and security when it comes to development of AI in our policies and in implementation and in action of public services. But in fact, we have been using for a very long time, we have been collecting and using data. We have been applying advanced analytics, and already now there's a big impact of all that on choices that are being made, decisions that are being made. And in fact, the debate on security and quality is timely and not only linked to AI, but much broader than that. For example, the scandals in the Netherlands on the benefits had nothing to do with digitalization or AI, but was much more about the action of civil servants too. So I think it's good that we have this debate. And maybe start also with the fact that AI, the basis of AI and the use of it in the public context is data. And when we are talking about data, then the question of security, how is data collected, how is it secure that it won't suddenly be all over the place and open or accessible to those who do not need to have access, is already a big challenge for public services and for actors in public action. And also the quality is just the same. If we know already, we use data, for example, for the calculation of budgets, etc., or for attribution of rights, access to some services. And if these data are not of good quality, and we know that often that's a problem, they are not timely, they are not of high enough quality, then it's a problem, but it will be even more a problem when we start using them in more automated systems where decision support or even action, immediate action, is the consequence of these data. So it's really a timely debate, and we are very open to development of use of AI. I can elaborate a little bit on what we are already doing in, for example, the sector of incapacity for work. We are already using today advanced analytics, and we are developing together with the public insurers, the mutualities, projects where, for example, models could help to evaluate the chance for people to get back to work with part-time working or with more full-time working. So if the data are not timely and of high quality, then yeah, AI will be not very useful or will come up with very wrong decisions or recommendations. So it's a very timely debate.
Thank you very much. Indeed, it's important. Also, great that you still highlighted the positive attitude that we have already, that you are using already application and that they are promising. Of course, flawed data results in flawed results. And now I'd like also to ask Steve, because we also discussed this morning that actually AI solutions don't come from the space, they lend to the actually regulatory landscape. And so I'd like to ask also Steve, is there any legal framework or procedure that allows to verify the quality of an application that Pedro just described?
Thank you for the question and the introduction. This is a very interesting space because there is much regulation already in place for AI in medicine. And it becomes a very interesting question, is regulation for AI in medicine in Europe applicable to the question of the application of AI in social security assessment? And it slightly goes back to what aspects the AI is actually used in. Very specifically, in every question about medical AI use, the question goes back to the intended purpose. So if the intended purpose is to carry out an assessment of disability. It's the very traditional medical side of the social security assessment carried out by a doctor. Then that is a medical device. What is the implication of that? very large. My colleague here will talk about the AI Act, and there's a new layer that will come in, but the existing layer has a very high level of requirements of the development of that AI within a detailed quality management system, the careful design for its use case, for the post-market surveillance, this question of showing that it actually works, even clinical investigation, so studies that measure it works, demonstrated that it works on market, demonstrated that it keeps working. And I've kind of got, in a lot of my presentations recently, I talk about mostly large language models and decision support systems in medicine. And I always start with a polling question. And I'm going to ask a little bit of a cheeky, non-Slido-based polling question related to work capacity, work capability assessment. In the US, are there currently tools on the market which will allow a medical doctor to perform a residual functional capacity assessment using AI? If you think yes, raise your hand. If you don't know, then lower your hand. So we've got a couple of hands raised at the front from those that might know best, because they're deep in these topics. It's slightly, I don't want to take up too much time with my answer, but when I was sitting in the audience at the first panel this morning, I asked ChatGPT to make me an example case of a patient with mental health problems, and it created me clinical depression. It created me a patient called John, and it gave me its clinical history. I took John's clinical history, and I went to another on-market US general clinical decision support system, non-medical device. It would be a medical device in Europe, non-medical device, and I said, this is John's medical history. It's quite a nice medical history. Perform for me a residual functional capacity assessment. And it gave me the answer. And it was quite good. Now, is it validated for that use case? No. It's GPT-4 based, but it's on market, and it's not technically, it's hard to say if it's legally on market or not, but it's certainly on market. The FDA has not challenged it. One thing we have in our regulation in Europe with the AI Act and with the existing medical device regulation is that does need to be tested. At the moment, there will be doctors, a guarantee, using that this second to do exactly that task, at least to give them the first output of data, which they hopefully would edit. But there's a lot that's been touched on: automation bias, the question of explainability, the question of human laziness from one of our keynotes this morning. If you're given a first draft, which can incidentally process hundreds of pages of medical history in seconds, and the technology could also process images and signal data, but is currently not doing, because that would clearly be a medical device in the US, we're already in a situation where the technologies can do it. Whether they can do it well is a different question.
Yeah, thank you very much, Steve. It's really important, and I think it's important that we have the regulation right now that already provides the control of safety and qualities to some extent, to some application that's a medical application. And I'd like also to use the quotes from the survey, because actually a lot of responders agree on the needs of the safety and quality control, and many rightfully actually mentioned that the impact is so high that actually we need, that's someone from Belgium, that we need the control. Then also someone mentioned that AI is a tool, and any tool should be verified before applied to the citizens. I think it's really important for the discussion, but AI is quite specific. MDR, Medical Device Regulation, was put before AI hype. And now we have also the first AI Act in the world. We will have probably in 1 week, or I'm sure that Jordan will tell us more about that. So Jordan, I'd like to ask you, what does the AI Act has to say about maybe also not just medical devices, like AI applications for medical purposes, but also applications that combine the functions of medical assessment and also like more broad work capacity assessment, and also like a social security application, how they will be classified, and if it's sufficient control.
Sure, thank you very much. So when it comes to the AI Act, essentially it is the attempt to kind of make sure that when we deploy artificial intelligence, it is in respect of our values. And the approach we've taken to that is a product safety and a risk-based approach. On the product safety aspect, I won't go into a deep argument about it, but it could be questioned if having a horizontal piece of legislation on artificial intelligence is the right way. Other countries have done it very differently. And as Stefan pointed out, there's also a lot of sectoral legislation already, especially when it comes to medical devices. So yeah, we have this risk-based approach. There's the low-risk applications, which are the kind of applications that don't require much oversight and regulation. The high-risk, which are the ones which do. And of course, the prohibited applications, which are too dangerous, in our opinion, to be used. So when it comes to these high-risk applications, there's a long list of different applications that are included. In our case, I think there are probably two grounds on which it could be included, the first being medical devices. And it's important to remember as well that the AI Act is complementary to existing sectoral legislation on medical devices, and that software, even standalone software that's not attached to a device, can also be considered as a medical device. So knowing those things, that's the first grounds. The second, of course, is access to public services and benefits, which I think we can say it applies in thoroughly as well. So those are essentially the two use cases which we're covering, and they are high risk. Because they're high risk, there are a certain number of obligations that they have, and we see it as a way of reducing the risk of these devices, maybe also filtering out some of the more dubious and less well thought out AI applications. So for example, you have detailed logging of what your AI application has done. You have explicit transparency on the input data and very high standards on the data that the AI is trained on. So in order to try to reduce the risks of bias, which I think we'll get into a bit later. Also, there are obligations on documentation. So the developer of the system has to provide adequate documentation and risk management tools for the deployer to make sure that essentially the person who's using the AI, the person who's deploying it, can do so safely. There are a host of other obligations which come with the AI Act as well. For example, human oversight, to make sure that there's always somebody keeping an eye on how the AI is behaving in order to ensure we don't find ourselves in applications and uses of AI which would not be reasonable, or in order to make sure the AI has not malfunctioned. There are also very strict obligations on reporting when an AI does malfunction to make sure that the problem is resolved and not ignored. So we've set up what we think is quite a robust safety net to avoid some of the obvious pitfalls of AI. Whether it addresses all of the pitfalls is another question, but I think it's a very good starting point. And so, yes, I think that it will help to reduce the risks and also help to bring citizens more trust in the systems that we're deploying. Thanks.
Thank you very much. It's indeed important that we have these procedures that help also to ensure, because one crucial issue or point that you made is that we should ensure that the AI application is reliable to the deployer and user. Because again, I'm repeating myself, there are the key stakeholders. It's really important that they can use safely the AI application. Just also quick question to all of you. We discussed already several models to regulate AI, to control the safety and quality, let's put it this way. And there are several legislation, also several procedures that establish it. So how do you think they match together? How do they help, like these two, to help to make it better, or it doesn't? Maybe it makes it too complicated, the regulation, like, because there is a tricky balance between facilitating innovations and like a lot of regulation doesn't do that, right? And also we should ensure the safety and quality. So how do you think also the procedures in the AI Act and the existing regulation overlap, and how do they help?
It's always the same. So we need obviously regulation, and the state cannot stay absent in the debate. But we were talking about a medical device regulation, and if we can talk about one regulation that also kills a little bit innovation, then often when I talk to industry, then they say that that's one of those regulations. I think what is important that we have a regulation that is quite, it can evolve, but it's quite a good framework where we can start from, and it comes together with other guidance, like at Belgian level. For the moment, the charter is being developed with public, private actors, academia, stakeholders, etc., to have principles on the use of AI in the public sector. I think all this kind of guidance, if it's hard regulation or more soft, makes us aware of what needs to be taken into account when we are working with AI. But we need to be aware that we are in a kind of learning phase. We are developing new things, exploring new ways of working. And I think it's important to create a learning environment that doesn't define in too much detail what can be done, what cannot be done, because we will miss out of some of the possibilities. But I think that the AI Act gives a good framework to start from, together with other guidance.
Yeah, Paul, do you have anything to add also to the points of Pedro?
Yeah, just that I think that the AI Act and the medical device regulation, they have an important synergistic effect. They work in an important way together. There is the aspect that when we're talking about a medical device in social security work capacity assessment, we know that the AI Act will apply. But also, as when Stephen was talking about, there may be aspects of this type of assessment that fall outside of the category of medical device. We know from what she was saying that the AI Act will also apply there, so the protection is broadened. And I think it's also important to remember that the MDR, the medical device regulation, it wasn't a patient rights instrument. It was created with a different function in mind, and its predecessor, decades ago now, and the focus was, more on safety, reproducibility, not on, for instance, transparency. And I think the AI Act clearly complements it there. So in effect, it has upgraded the medical device regulation in this regard.
Yeah, that's very true. I think also Steve has something to add.
Yeah,
very quickly, because we need to go.
I'll make it quite quick. Like, if I was working in industry in an AI startup, and our product was for social security assessment, and I was working in the regulatory and compliance department, and I was asked by the CEO to come up with an argument of how our product was not regulated by both the MDR and by the AI Act, I could do quite a good job doing that. But I would strongly suggest not to take that approach. And the reason not is the big word blunder. So work capacity assessment in the UK, you may be aware, is labelled as is not an AI-based approach, it's a paper-based approach, has been labelled as one of the big policy blunders, and it's going out. It came in, and it's being replaced by something which may be a second blunder, but we'll soon see. There's a very, very large risk of trying to find ways outside regulation and actually not adopting, in the end, some sensible principles that one should be observing, which are many of the things we talked about. The differences of regulation says they have to be done, things like transparency, things like visibility. And I think within the sector, it is so controversial that the entire area will be labelled as a blunder for many, many years if people try and go outside the regulation. Like, for example, how one could go outside the AI Act. It would have been very hard to go outside the high risk in AI Act, which is a big differentiator. If you're not high risk under AI Act, most of the reporting standards are relatively low level. The comments previously about applications in social security being as high-risk AIs and then being under a notified body with a CE marking process and so on, conformity assessment, that they're there for good reason, but they were weakened in the latest stages or the latest drafts of the AI Act, and there's a level now where if it's assistive decision support but there's human in the loop later, or if it's an early risk assessment, or if it's a later summary process, you could make an argument that you're not high risk. You could also make an argument under MDR that you're not involved in the actual disability assessment, you're involved in the conclusions after the disability assessment. If I was working at a company again, my job, I would be paid to maximize shareholder value, CEO ownership value, to make those arguments, they're short-sighted and they would really just result in damage to the sector and to people.
Yeah.
I mean, you kind of took the words out of my mouth there, Stefan. I mean, the UK was one of the first countries, where I also grew up, was one of the first countries to deploy the digital work assessments and heavily digitalized work assessments. And recent research has found that it resulted within the first 3 years, I believe, in 600 suicides. And so I can't stress enough that, yes, innovation is important, and yes, regulation does sometimes limit innovation, but there are very, very good reasons for that. And if we want to have the public's trust, then it is absolutely vital that we're very careful how we regulate things and that we create an environment where they feel like high standards are being applied. And so, yeah, I think that's absolutely vital, and that's why I think the AI Act is actually a good thing.
Thank you very much for these insights. Indeed, it's really important that what we have already, but for sure, this specific sector, work capacity assessment, should also be, the work in that also should be continued, because it's rather specific. It combines different AI applications. So it's also nice to continue work in the implementation phase of the AI Act. And now I'd like to move to another challenge, which is discrimination and bias. Actually, one of our responders specified that, to his or her opinion, it's the most important issue. We already discussed this morning like there are different perspectives on the issue. Like some say that actually AI may help to make decisions more objectively. On the other side, there is a lot of sensitive data that might also hide the latent biases. And if AI makes decisions on these biases, then the decisions are also biased. So. And this, another perspective, the positive one, was also shared by the responder from Norway. And now I'd like to also give the floor to our panelists to discuss this important issue. And I'd like to ask first Paul, could you please also, as you specialize in discrimination and stigmatization issues, could you please describe us the challenge that is might exist in the applying AI in work capacity assessment?
Okay, thank you very much. A word of caution, first of all. I am not an expert in work capacity assessment specifically. I work in analogous areas. Taking this into account, I decided to do a little bit of research yesterday and the day before to inform myself. And the research did indeed inform me, because I quickly noticed that there is a lot of literature on work capacity assessment. There is not, however, very much literature on AI in work capacity assessment. So I found 1 or 2 papers that touched on it. So this is an area I would first call on. Before we can definitively say what the challenges are in this area, we need more research in this area. However, we can draw upon our experience elsewhere and on the literature on work capacity assessments in general. And this, I would also tie into the previous panel, because it's clear if you look at the literature on non-AI-based work capacity assessments, it's clear there are already a number of problems, many problems. There is already bias, there is already subjectivity, etc. So I would link it to the previous panel, Professor Minsons. When, you know, we should not think that AI will just bring harmful effects. We have to bear in mind the positive effects also. And at the moment, without AI, we have many negative effects. However, we obviously have to take into account AI is a double-edged sword. Whilst it has the positive to address many of these negative effects at the moment, it also has a positive to bring with it some negative effects of its own. So, in the notes we discussed before this, there was mention of discussing bias, discrimination, stigmatization. A quick word on those concepts. They are all related, but conceptually very different concepts. For example, bias is often thought of as statistical, mathematical concept, maybe also found in sociological literature. Discrimination is very much a legal concept. lawyers like myself generally feel more at home discussing discrimination because it's precisely defined in legal terms. Stigmatization, on the other hand, is predominantly a psychological and sociological concept. I prefer the psychological understanding of it, where it's about a person's perception of others in society. This is not something lawyers are comfortable with dealing with, and it's not something that any piece of regulation can tackle. It's a very complex phenomenon. And the same with the other areas, discrimination and bias. We should not look to one single legal approach to solve these problems. It's not realistic to expect this. Rather, we need to look in a range of areas. And we've looked at some of these today, the AI Act, the medical device regulation. We also have national laws on discrimination. Like work capacity assessments, these vary across the union, where certain categories are protected more than others. So we have a very diverse picture. And when I look in the literature, I see three main areas where all of these things could be present. And obviously the form of work capacity assessment varies across the union. So this is my attempt to generalize the three processes. The first would be the original medical diagnosis of disability. And we all know that there is a problem of representation in scientific research regarding health. There are many examples concerning minority, gender, etc. I would probably add class to that also. Then we have the second, the assessment of impairment. I'm thinking recently of the example of misunderstanding and bias regarding endometriosis, for example, how much that impairs somebody in their work ability. I'm by no means an expert in this area. I'm just quoting it because it's a bit topical at the moment. All the biases in this area could feed into any AI potential solution we should use, so we should bear them in mind. And then assessment about how impairments will affect labour market participation. From the research I did, I looked at this third step is handled differently in different countries, but essentially where it is taken into account, there is an attempt to see how impairments will affect a participant's ability to find a job in current labour market conditions. Obviously, there is a potential to import bias from the data there. The labour market is full of bias and discrimination. It always has been, it always will be. We have to be careful we don't import the biases there into the work capacity assessment. And something I was discussing last night at dinner with my colleagues, for me, I see two risks. One is the obvious risk of people not getting social security entitlement that they clearly deserve. That goes without saying, we all know this, but there is another risk that if we import biases from the world of work, etc., that sometimes people may be declared unfit for work where they could actually find work. And it's by no means good for people to be put on to be put on sick leave, essentially, in the long term when they should not be. That's not also good for individuals. So there are two risks, and they should both be borne in mind. And yeah, I think I've outlined the risks. The rest I'll leave to later. Thank you.
Thank you very much, Paul. So the challenge is really well described, but now we also would like to come to the solutions as we keep the positive attitude, right? So looking for the solutions. So I'd like to ask all other panelists, how do you see the biases and discrimination and in data, the existing biases, but already like to prevent them for training and the development of legal other solutions? How do you see it might be solved? So I'd like first to ask, that's a tough question, I understand, but...
Yeah, I agree with anything my neighbor said, and I liked the end where he also stresses the fact that today we don't give the right to go to work because people who are fit for work, we don't let them integrate in society, and we don't give them the support to do so. So I would like to stress that again. I think, as I said, we need a learning environment. So if we want to challenge away a bit the way we work today, the human factor, where each, for example, each doctor, controlling doctor or advisory doctor in public insurers, for example, evaluates the possibility to restart working again. If we let that a bit challenged by models that kind of give an advice, but then we discuss about it in a sort of collective way, not in an individual way. What we open up the discussion between multiple doctors, where we challenge each other on the basis of, but not blindly following this. Also discussing with the regulator, in this case also my institution, the National Institute for Health and Disability Insurance, also with representatives of people who are in incapacity for work, who come with their view too, then I think we can evaluate what biases are in the models themselves, because we cannot rely on the current data. We have today very ineffective policies to date when it comes to reactivating people. So if we would just work on that data, we will not let the machine advise a lot of reactivation too. So I think we need to challenge the machine by people, and we need to have multiple people, multidisciplinary people who can look at this from different sides, and also the clients who are the object of the system to give their response to that, and in that way improve also the algorithms that are linked to it.
Thank you very much. Indeed, sharing is caring. And yes, I think cooperation is extremely important, and interdisciplinary dialogue is also crucial to avoid biases. So the more we focus on preventing biases, the more chances that we avoid them. So I'd like also to ask Steve on the solutions, or your opinion on the topic as well.
So I'll name the solutions. I'll do a little bit on an aspect of the problems I don't think we've fully covered, and I'll come back to the solutions. But one of my questions earlier hinted at one of the solutions. It's a very scary thing called transparency, and it's actually radical transparency and visibility on how well systems work. And there's a second aspect, which is independence of evaluation. If you're marking your own homework, you never improve. And we are in a situation where the homework needs to be marked with these technologies. Well, I said I mentioned something about an aspect of the problem we've not covered. When we're talking about the application of AI in work capacity assessment, particularly on the more medical side of work capacity assessment, we're talking about one of the biggest multimodal problems in medical assessment. Why do I mention this? There's been a lot discussed, and it was touched on in the keynote talks this morning, about the different epochs of AI. So there's initial rule-based systems. This is kind of sometimes described as Epoch 1. Epoch 2, which is deep learning, but applied in narrow use cases. And then we're moving to Epoch 3 and some of the technologies which are coming along, which allow the assessment of multimodal data. What do I mean by that? If you're doing a residual functional capacity assessment using the US language, you're looking at all aspects, all problems of the patient. You may even be looking at signal data. You may even be looking at images. Bias is a huge problem when we're talking about medical devices, to find a nodule in a chest image to say if there's a breast cancer or a lung cancer or not. Even there, in order to get your X-ray images so that they're representative of all populations is a hugely difficult task. If your AI is for diagnosing melanoma from skin cancer, there's a huge problem, and you can define it. Recently approved EU and US tools for using Dermatoscope to use AI to say if you've got a melanoma or not, for a doctor to say if you've got a melanoma or not. Those have a defined level of bias based on skin color. They're a single narrow use case, the image skin, they've been trained on sets of data. Then you're shifting to multimodal, where it's not only one stream of data, it's all the streams of data simultaneously, and the problem of bias is absolutely enormous. There's bias in the original data, so even a transparency, a visibility on the transparency data. For the multimodal approaches and the more Epoch 3 approaches, it's kind of, as I was touching on the panel this morning, it's everything. It's Reddit, it's all of PubMed, even the wrong stuff, taken together with all of its inherent biases. The bias problem is not easily tractable. It was touched on by the CEO of Google, whose name I always mispronounce, so I won't try, on the recent problems with the founding fathers of the US when asked about being shown as black founding fathers. That's a overcompensation in constraining certain approaches within AI, and it's also related to the training sets of the AI themselves. It's an inbuilt problem. That's one example where they really face a very large problem in solving it, because the bias is built in from so many directions. Once you get to these multimodal approaches, there's no easy solution. So therefore, my solutions are work within the regulatory frameworks where you adapt. They may need to be adapted. Radical transparency. In other words, scary. The public might actually see how the systems perform. Testing from independent test parties, even citizen science, where you actually have example cases and people can develop example cases, vignettes we sometimes call it, and actually apply and see what the results come out are. In a system where it later comes out, after the 6,600 suicides or after the 1,000 children have been taken into foster care, is the policy blunder beyond all policy blunders. So instead, it doesn't actually mean don't innovate. It means innovate with feedback on how you're actually performing, being brave enough about real performance. And that's a huge, huge challenge. But I really do advocate, I lobby for that approach.
Yeah, and like you, again, very accurately described the challenge, some of the solutions too, but also as we see the AI Act is aimed to bring the solutions in terms of regulatory approaches. So Jordan, what do you think how the AI Act actually might help or might not to control biases and discrimination in AI applications?
Well, I think there's good news and bad news. First, and I think the reason for that is because there are two different types of bias that we have to deal with. The first type is the easy one. So it's just the fact that a data set isn't complete and representative of the users of that data set. And I'll also just add, while we're at this, depending on the country, the users can be very different. So one data set doesn't necessarily always fit all, but that's a side point. You mentioned endometriosis. You mentioned the difficulty of diagnosing people with skin cancer when they're people of color. Those are problems that are due to the data set. Essentially, we don't have the right data to solve the problem. Those we can solve, and the AI Act mandates essentially, I think the exact wording is a data set that is sufficiently representative. And that's great news because it means that in the future, this sort of application is going to have to be very well thought out, and that data is going to have to be very carefully chosen. The bad news is there's another type of bias, and the clue is in the word representative, because building an AI that acts the way our current society acts is not necessarily building a good AI. And the issue that we actually have is we don't have a data set of a perfect society. I mean, you can look at it, for example, in the case in the United States with recidivity, so people who commit a crime after they've been in prison. We've seen that it's biased against people of color. And the problem is there's no data set in the United States where there isn't bias against people of color. There can be similar problems in the health and particularly in social security sectors. So we can solve half the problem, but we can't solve it all. And that's, I think, really where the challenge remains.
Yeah, thank you very much. At least there are some good news. And I think it's also connected to the discussion on the European health data space, because this is actually the way to get the data that we need. So I keep advocating for the HDS. Sorry about that. And so now we move to the last, but definitely not least topic. And here I'd like to start with, again, another quote of one of the responders. That's one of my favorites. If it works, then I'll show it to you. Yes. I'll do my best with my French. C'est toujours utile de mieux connaître ses potentiels ennemis. So it's always useful to better know your potential enemies. This is the person, of course, from France. It was in French, of course. And I think there is a lot of truth in this statement, even though it's a bit ironic, but actually it's really important about AI, the risks, but also the benefits. In a more nice way, it can be said also, as another responder from the Netherlands said, people need to know and must be aware of what the abilities, but also the shortcomings of AI are, in order to use it in the right and ethically correct way in their work. So I'd like to open with the statement also the discussion of our last topic. We discussed black box explainability a lot today. I think also it's important to remember that besides the technology, there are also human approaches behind the technology. There was also the statement of the European Parliament on the importance to differentiate between the transparency of AI and transparency of the development and use of AI. And I think this is what we need to keep in mind. So without any more suspense, I'd like to ask Pedro to share the vision on what actually healthcare professionals and insurance physicians should know about AI applications so that they can rely on the system, so that they can trust the decision, because it's difficult to assess the decision, to verify its correctness, but also besides there's maybe another type of information. How do you think they should be informed?
First of all, preparing this, it made me realize that we are already using so many things, not only technological instruments, but sometimes just flow diagrams, etc., or procedures that kind of do the same things, but when it's in technology, then it's suddenly AI. But when we have like flowcharts to categorize people or situations, then we are doing a little bit the same, only it's not operated by a computer, but it's operated by a brain. I'm not sure what is more disturbing. And probably it's the interaction between the human and the computer that can solve that. So I'm still optimistic about that. I think that, having said that, I think that it's already important to also as public authorities to be very clear on what is already being used, what we are using, what we are testing, and being very open about it. I've heard the concept of radical transparency, but for example, for an institution as the National Institute of Health and Disability Insurance, we need towards the stakeholders really have an open dialogue on what we are doing, why we are doing it, how we will evaluate it at our level, but also academic level. And I think that's the most important, to create this explicit debate and having the discussion, because today we are not discussing that much. But it made me wonder about so many things. We are distributing for such a long time guidelines also on good practice towards medical doctors. It's also a sort of tool. We don't know how it's being applied exactly, because everyone's free when he's making his diagnostics and treatment. But I think we need to have much more discussion about it, and creating again an environment, multidisciplinary, where we discuss what we are doing, what are the results of it, and what are also the pitfalls we need to solve.
Thank you very much. That's really a key message that you also shared, that it's important to see transparency in a broader perspective when, for example, AI developers share with users and deployers in the human language, not in the AI language, on what are the capacities, what are the risks, how to better use, what kind of data should be put in the system, how to verify the correctness of the algorithm, and, for example, when to push the alarm button, for example. So this is really important, the cooperation and common dialogue between all the stakeholders involved. I'd like also to ask Paul, what do you think currently legal or other mechanisms that might or might not ensure transparency, and how also you see this issue?
Well, the original medical device regulation was a bit weak in this area on transparency, but it has been, you can say, upgraded now with the AI Act. And the AI Act contains in Article 13.1 a requirement for transparency. You can read it on paper. I will be honest with you, I don't know what this will mean in many contexts. I find it very hard to envisage what transparency will be for a doctor using an AI program in a work capacity assessment. And I find it a bit unrealistic to expect doctors who are trained in medicine to expect to become data analysts and experts on bias, and beyond providing some infantilized representation of what is happening. I really don't know what this will mean in practice. And I find it very strange because we don't expect doctors to know how MRI machines work or other pieces of highly sensitized equipment, sensitive equipment. So I think we're expecting a bit too much on transparency here. I mean, I see a role more for transparency in retroactively going back and dealing with disputes and appeals, etc. But transparency for the professional using such a tool at the moment, I'm quite skeptical about what that will mean in reality, especially for doctors who are very busy people. Try and get an appointment and you realize how busy they are.
That's very true. Actually, also one of the respondents mentioned that it's really important the time that they should spend to interpret the outcomes of AI. And if it's too much, all the benefits are lost. So indeed, it's really important. But as you mentioned the AI Act, I should first also ask Jordan. There's, again, like famous Article 13, famous for lawyers, sorry to be boring, but there is a specific article in the AI Act devoted to transparency of AI applications. It says that outcomes, you might correct me, that outcomes should be interpretable to users. And also, besides of that, there's a list of information that should be provided to users. So, reacting to the Paul's comment, do you think it's a sufficient solution for transparency? Because there is still the issue, and if yes, why? And if not, also why?
Well, it's a difficult one for me because this is one of the things that, as a committee, so the Legal Affairs Committee, we were simultaneously the most proud of and the most frustrated about. We spent essentially the entirety of the time we were negotiating trying to address this issue. And what we came up with is inadequate, but the best that we think is technologically feasible. So what we have is essentially a set of transparency obligations and this was our particular edition, the right for subjects to have an explanation of how the system has affected them. The problem with that is, as we all know, the way that artificial intelligence comes to answers is not transparent. So it's not that simple to know what the outcome or how the AI system itself reached the outcome. And in some cases, that's less problematic. Like you said, a doctor doesn't necessarily understand how an MRI machine works, and that's fine. That's okay because an MRI machine is a lot more objective than a work capacity assessment is. And I think that herein lies the real problem, the thing that as I said before, can't be solved. We can develop AI applications for medicine, but I don't think. And I'm sorry, Timo said it earlier. Our former moderator. Thank you for finishing my sentence. I appreciate that. He said it earlier that he sometimes feels like he's pouring water on the bonfire, and I've got to pour a little bit of water on the bonfire. I think that we will see a lot more use of AI in medicine, where we're objectively looking for patterns and trying to find things. I don't think it's ethical, and I don't think with the current state of technology that it's possible for us to assess if somebody is capable to work on the basis of artificial intelligence. I just don't think that's going to happen now, perhaps in the future. But as of today, I don't think it's possible. I think AI is going to help us make evaluations. I think it's going to help us do analysis. But I don't think that it's yet capable of evaluating individuals' capacity to do things. For that, you need another human being. And I don't see that changing in the near future. So more use in medical applications, but not in work capacity assessment. And I'm sorry.
Thank you very much. We are a bit out of time. So Steve, if you want to react also on the bias issue, feel free to quickly do that, and then we go to the Q&A session.
So I'll try and be quick, and I think the question touched on explainability and transparency, and there's slightly different aspects. I've touched on my view of transparency. I am enthusiast, and in my work I try and promote the more open use of decision support systems in medicine. Like Jordan, I'm a little bit cautious with the introduction in work capacity assessment more than medicine. I actually see these things as slightly conflicting with each other. I mentioned it before in the context of wearables data and the sharing of data. If the explanation came to the patient, you've been assessed as being fit for work when you don't think you are, because 5 years ago or 2 months ago you shared information using your Fitbit, actually saying that you, which actually shows that you are capable of running upstairs because you have the speed at which you went upstairs. I don't think that would be transparency and explainability, but I don't think should be in a situation where we're explaining to citizens how there's been intrusion they didn't really understand in data. And if we go to the area of explaining to doctors, explainability, there's an explainability paradox in decision support systems in medicine in general. It was touched on by the keynote speakers this morning, both of them. Unfortunately, more explainability can make medical decision makers worse. This was touched on for the radiology examples, but there are many, many examples of this. There's a huge debate in decision support systems about providing more, where the doctors then starts to question their own judgment, versus providing less, where I argue in a paper that I've about to come out in quite a major journal, that the role of the doctor without explainability disappears entirely. What is the role of the doctor if they're neither making the final decision, because they don't understand what they're making it on the basis of, nor being liable for it, because the AI system is liable for it? And I, in my work, promote this idea of getting explainability to work. It's immensely challenging, but we really need new science around explainability. It's not something you tag on at the end. It's training doctors to work with these technologies, accepting that most of the evidence shows at the moment the opposite direction, which explainability doesn't help. But we need to get explainability to work, or else there is no role as a doctor. That sounds strange. There's no role of a doctor in the diagnostic process if they get information from multimodal AIs where they don't understand where it came from, based on data they couldn't possibly interpret in the same time, and they couldn't come into judgment. That would apply in the same way to work capacity assessment. The AI has interpreted 50 items of clinical record. In 3 seconds, it's processed numerous images and numerous signals, and it's given a judgment, and it doesn't give you any explainability of why. It just says, I interpreted the whole thing, give it all together in a model where things were weighted together in the model. I've given you the work capacity assessment. Of course, I can't explain it to you. It's AI stupid. What's the role of the doctor at all? How could the doctor be making a final decision on this? What we need is to really have a proper science around getting explainability to work, rather than saying it doesn't work, or we need to radically accept that doctors don't do diagnosis anymore. And their role in doing therapy is, I work a lot in robotic surgery, etc. That's not, and we touched on this morning, it's the higher level professions that are in some ways the most subject to change. So there's a kind of reality check, but in the diagnosis level, explainability needs to be got to work.
Thank you very much, Steve. I do agree that's really important, and we should be bold about what we want to achieve. Now I think that's the time to go to first of all, to thank our panelists. Please give applause. And now we have a bit of time to address the questions from the audience. So if you have any, or you want to claim your authorship as well, feel free to take the microphone. There's...
Thank you very much. My name is Regina Kunz from Switzerland. I'm a researcher and a practitioner in medical assessments or in insurance medicine. Thank you very much for the discussion, and I found lots of things confirmed which I have observed in the last years when I was occupied and dealt with these issues. I want to make 3 comments. The first one is I think we need quality criteria. Now, the first thing is we need more research in this area, in assessments. Yeah, I entirely agree there is no research. Your observations that in work capacity assessments you find lots of literature, but only 2 which addressed IE. I'm pretty sure that lots of insurance companies, private insurance, but in the same way public insurers, they try to find out what they can do with the data they have. I mean, insurers actually have the most structured data in the whole health and social security system, but we do not learn anything and they do not publish this data. So I really think we need more systematic scientific research published in scientific papers so that we all can learn from this experience. So lots of things are going on, we do not learn from it. I think one of the things why work capacity assessments are so quite difficult to reproduce in humans already, but even more to reproduce in IE, this is what I think, is because there are at lots of levels there are judgments, there are value judgments, and the machine doesn't have value judgments. And I think from my communication with people, they do not mind to have value judgments in the system of work capacity assessments. So there are things I think which will definitely a machine can put together and make a cluster and an algorithm out of this, but not with value judgments. And perhaps, and I think we need quality criteria. If it gets into the application in practice, we need quality criteria. Of what the value of the machine actually is, what it adds, the caveats, and people need to know that they use. Doctors need to know that there's such a tool in the background. I'm not sure from your survey whether you got information on this. Do doctors actually know that there's a tool in the background when they work in their work environment in medical assessments? And this guide, I think this needs to be guidance, more or less. They don't need to be or shouldn't need to be hard criteria, if you like a checklist. This is done, this is done, this is done, and this is a level where above you can do this and you can trust it, but below you cannot trust it, rather than guidance. And I think doctors who have to deal with guidelines anyway, they should be made sufficiently competent so they understand the tool that is used in the background, because only then we can discuss with each other, is it really trustworthy, is it not? Then we can sit in a panel and discuss on multiple disciplines, what do you think, how do you trust these results or not? And I think I leave it by this.
Thank you very much for the insightful comments. Would you like to react on the comment?
Yep. From my short career researching this issue, I did see there was some literature on the assessment of liability following injury that is somewhat related to this. So I guess if for those who want to go further in this area, that would be a good starting point. But as you say, there's a massive gap. Yep.
I have a tiny comment on the ability of AI to make value judgments. So current Epoch 3 AIs simulate the ability to make value judgments. The tool I mentioned before, which was questionably in its legal status on the US market, that I used to carry out a residual functional capacity assessment, made value judgments, or it simulated, it read as if it was making value judgments. And that was based on GPT technology, which could be used in the US until it's challenged in courts that will not strike it down. They're not pro-FDA courts if the FDA challenges it. Currently does make value judgments whether it should or not. And there's a whole science behind value judgment approaches going with Epoch 3 AIs. You'll be aware of the company Anthropic, which is one of the biggest players in this space, which are developing exactly value judgment models to go with AI. So I think if we look at Epoch 2, if we look at a machine, deep learning machine trained to technologies in an X-ray, it doesn't make what looks like a value judgment, but I don't think we can say that the technologies which are coming don't do things that look like value judgments.
Okay, no, but one comment here is if you make medical assessments with regards to work ability or inability, we also look at the history of people. And even in the history, there are always value judgments taken at different steps.
And those examples also look at history. So I gave a history in this example this morning. And it would take those value judgments in the history and it would infer, just as a medical doctor would, whether it does it right, accurately, without bias, or whether I would personally prefer the technology had never come about, is a different question.
I agree with it, but what I like of this discussion is that it also makes explicit that already today, think away the computers and the AI. There's so much values in the decisions we make. In policy science, there's a whole branch of research on the discretionary power of civil servants, often in local services, where you see that regardless of very detailed regulation, people, and regardless of strategies and the work people like me do to have shared values in an organization, there is a very different way in how regulations are being applied. And this is, I think, computers and artificial intelligence can help us to make that debate more clear and maybe to challenge that. And only in the Belgian context we see that the behavior and the way, for example, the doctors of the mutualities, and there are some people here in the room, the way they evaluate people and the way they evaluate also the possibility to go back to work are very, very different. And it's linked to values. So if the values are values of people or values that are indirectly through models reproduced by computers, it's the same debate. And we should be much more explicit on it.
Yeah, if I may, let's go back to the point on value judgments very briefly. Let's say hypothetically AI can make value judgments. I think it's still very questionable. I don't think that it can yet. But let's say hypothetically that it can really make value judgments. I actually disagree that it's the same, because the issue that you end up having is from the moment we start using AI to make these decisions on the basis of past data, we condemn ourselves to continue down that path in perpetuity. And that's a massive, massive problem. Because yes, humans aren't perfect. We make mistakes, we do things wrong, but we have the capacity to self-improve. And if we want, yes, does AI have the capacity to truly self-improve? No, it doesn't. It's using the same data that it's always used, and it's reproducing the same results, meaning that the future data will be the reproduction of the existing situation. So the question that we kind of have to ask ourselves at the end of the day is, are we happy with where we are, and do we want to continue that way in perpetuity? Or do we genuinely want a system where there are human beings in the process and where the results are evolving, hopefully positively? And so I think it's vital to keep that in mind.
Thank you very much. I think it's a really important message. I think we can also think how we can verify the data and to ask ourselves, humans, what us humans can do for other humans who deploy AI solutions. Are there any other questions in the audience? Yeah, maybe the last one, because we are a bit out of time.
Hello, I'm Tom. I'm a researcher in law at VB, and I have a question for Pedro and Jordan. And Pedro just mentioned that to mitigate the issue of discrimination and bias, we should challenge the machine by people to improve the AI, the algorithm. And Pedro, Jordan, you mentioned that the good news is that we have sufficient representative users for that. However, I'm quite skeptical about the representativeness of the users, since we know AI is quite new and there are several groups of people who cannot access it and who are excluded, and they could not access the technology, and in turn, they could not contribute to the training of the algorithm. So my question is, are there any mitigation measures or policy to guarantee the representativeness and also to guarantee the inclusion of the technologies? If no, where is the direction to guarantee that? Thanks.
Okay, if I've understood well, then it's about the fact that not all the doctors use the AI, or sorry, maybe you need to clarify a little bit because I didn't hear well.
Not all the doctors who use the AI, it's just like the users who use AI, so their data could be the materials to train the AI system, the algorithm, but we could say that there were several groups of people who are excluded to use the technology. So maybe the representativeness, we cannot guarantee that. So are there any mitigation measures to solve this issue, and how can we include more people?
Yeah, I like questions I have no answer to, and I need to think about. It happens all the time. I cannot immediately react to it, so I would need to reflect a little bit on that. In the end, I think that I'm thinking a lot about the context where, for example, if we were talking about evaluation of incapacity for work and possibilities for reactivation, then obviously, in my opinion, we should be able to guarantee that all those who are in that job use and are able to use some instruments in the same way. So it also needs training. It's clear. So we need to get everyone on the same level. But I'm not sure if I reacted to your question. I will think about it and I will come up with a decent answer.
I'll try to keep it short. I think the one thing that we can do to help address this problem is instill a certain degree of care and maybe hesitancy when using AI. I think one of the problems we have is right now, as a society, we see it as this magic wand that you can wave, right? We need to stop looking at it like that. We need to start looking at it like a tool to help people and a tool that we have to question. And I think that's the best way that we can improve the AI systems that we've deployed, is by questioning their output and working to try and improve it. And that's
Thank you very much. Just very quickly.
So it's a tiny point that kind of links points made by Pedro and Jordan previously. And this, Pedro's made this point about the weakness of humans in decision making. And Jordan's made a few points about the weakness of AI. At the moment, that weakness of humans is very rarely brought into the spotlight. And the thing that I'm proposing of great transparency around AI would actually bring the weaknesses of human decision making into the fore, and we're really not ready for the weaknesses of medical decision making or social security medical decision making. We couldn't cope with certain aspects. So there's a certain immaturity in society and the political discourse that can't really accept how poorly human decision making processes are, and that's why we're in a bit of a conundrum about introducing any AI decision making processes.
Yeah. Thank you very much. Just to take one extra minute, because I'd like to also ask participants, our panelists, to give 2 words recommendation on solving the challenges that we discussed today. It might be 3 or 5, that's okay too, but just really quick action point. Pedro, please.
Learning and transparency.
Okay, thank you.
More research.
As a scientist, of course, you will say that. Steve?
More money. Don't build systems where those that build them can't be honest about their performance, because if they speak up, they would get fired.
That's mysterious, but yeah, thank you.
And use AI for objective, not subjective tasks.
Thank you very much, and I ask you to say thank you and give a huge applause to our panelists.
All right, thank you very much for this panel. I also would like to thank our moderator, and I think that she deserves our applause, Anastasia Kiseleva. It was very insightful, and we'll continue after the coffee break with the third and last panel of the day. So I invite you all in the hall room to enjoy a little break. We'll see each other in 20 minutes. Thank you.
All I see is blessings, got no time for stressing. Don't believe in failures in my life, it's only lessons. They just making room for what I'm on now. I don't got a clue, but I know the one who does know how. Oh wow. It's like I'm learning the game with the maker I already know now. Destiny has my name, know it's coming, it'll never go. I know that we all gonna be alright. We gon' make it through if it takes us all night. No matter what the odds may bring our way, I can see the blessings coming our way. Yeah, yeah, yeah. Blessings on blessings, yeah. I can see the blessings coming our way, our way, our way. Blessings on blessings, yeah. I can see the blessings coming our way.
I can't say that life's been perfect or complain, cause life's been worth it. And all because of who he is working, only working out for my God. And no more living in that fear, no more tears and no. Oh, he's working me and molding me, who he wants me to be.
I know that we all gonna be alright. We gon' make it through if it takes us all night. No matter what the odds may bring our way, I can see the blessings coming our way. Yeah, yeah, yeah. Blessings on blessings, yeah. I can see the blessings coming our way, our way, our way. Blessings on blessings, yeah. I can see the blessings coming our way.
I can see the blessings, I can feel your presence. Leaning on the change in my heart for your endeavors. I pray I'm your reflection, I fiend for your